This is an ABC podcast.
Hello and welcome to the Health Report with me, Norman Swan. Today we're going to look at new findings for women with ovarian cancer. But first, after the overthrow of the Ceausescu dictatorship in 1989, Romania was open to the world for the first time in decades. One of the horrifying aspects of the regime was that they'd outlawed both abortion and contraception and put a tax on couples who were childless. The result was that thousands of babies and toddlers were abandoned and ended up in appalling orphanages. Around 170,000 orphans were discovered languishing in the harsh conditions of hundreds of institutions. A generation of children who'd been brought up without care, stimulation or comfort. And it prompted a comprehensive scientific effort to study the effects of institutionalisation on these children's well-being. Studies which might also help understand the effects of disadvantage in early childhood more generally. Many of these kids were adopted by foreigners in the 1990s, and some went to the United Kingdom, where they've been followed for more than 20 years into adulthood. Edmund Shnuga-Bark is Professor of Developmental Psychology, Psychiatry and Neuroscience at King's College London, and he's the senior author of a recent paper looking at brain development and function in a cohort of Romanian orphans who've been followed for decades since they came to the UK. I spoke to him earlier.
No problem.
I've covered this story from time to time over the last 20-odd years as these children have come out of Romania. We'll talk a little bit about the extraordinary circumstances in which they were born and they've spent the first little while of their lives.
Yeah.
But given that, why can we extrapolate that more generally to disadvantage?
Well, of course, we haven't made the claim that we can. The question is, can we extrapolate? And I think we have to be careful in extrapolating. This is a very particular form of disadvantage, and it's in its worst form, a very extreme form of disadvantage.
So tell me their stories.
Yeah, so the story is an initially heartbreaking story that burst onto the world's media in the end of the 1980s and the beginning of the 1990s when the Ceausescu regime fell. And people had known or heard about these really brutally depriving orphanages in Romania. They'd heard rumours, but the media went into those institutions when the regime fell and broadcast the pictures around the world. And I remember them very well. I think people of a certain age, it was one of those iconic images of those poor, sort of emaciated kids staring blankly back into the cameras that really hit people hard. But for some people, of course, they did more than be upset. They actually went over, rescued the kids, adopted them and brought them up in their own families.
They were effectively underfed, kept in a cot and not given much love and attention.
Yeah, that's right. We describe it as global deprivation. It was devastating in its breadth. So it was both in terms of diet, in terms of hygiene, in terms of communicable diseases were very, very common. Mortality was very, very high in these institutions. But more than that, there was a kind of a complete lack of interaction with adults, so no opportunity at all to develop those kind of vital attachment relationships, and very little cognitive or social stimulation. So it was kind of a whole package, a very toxic package of adversity, of neglect and deprivation.
Now, you followed them up and they're now in their 20s, nearly 30.
Actually, now in their early 30s.
Just briefly give us a picture of what they were like as children, as babies and children, and how they've developed before we get onto the brain scanning.
So they typically arrived after spending between, say, 2 or 3 months or up to 3.5 years in those institutions. They arrived in the UK into their adoptive families. Across the board, there was a devastating impact of that early deprivation. So developmentally, they were very delayed. Physically, they were very, very stunted, very small and very light. So a lot of subnutrition. And quite remarkably, as they grew in those adoptive homes, there was an enormous pattern of catch-up in the first 2 or 3 years for nearly everybody. That was the first really remarkable thing. But since then, for a really large minority, there have been a persisting pattern, a very persistent pattern of a range of difficulties. So not everybody, and this is an interesting question, of course, not everybody, not all of the people have been affected, but a large proportion have, and they have a very distinctive kind of heterogeneous pattern of difficulties, particularly around what we call neurodevelopmental problems.
So these are things like attention deficit hyperactivity disorder.
Yeah, autism, attention deficit, and this very characteristic pattern of so-called disinhibited social behavior. So this inappropriate approach to strangers, inappropriate friendliness, a lack of awareness of kind of social risk, lack of awareness of boundaries and so forth. So that was a very characteristic of this group.
Which is frontal lobe, isn't it?
Well, that's what we're looking at now. Long story short, these problems have persisted right the way through to adulthood, really against expectation. Don't forget, they've been in, really, on the whole, wonderful adoptive families.
Gone to normal schools, well-nourished.
Well, more than normal. I mean, super enriched in a way, because very often these families had considerable resources. They provided, as far as they could, exceptional care and support, and still do, actually, I have to say, wonderful families and wonderful young people, and they still do provide that support for their young adult children. So it's almost like super enrichment, and despite all of that, 20, 25 years of that, those marks of that early neglect are still there.
How many of these children are we talking about?
In our study, the cohort we looked at was around 400 children were adopted during the period that we were recruiting, and we had 165 adoptees. And that's an extraordinarily large number of children having such an extreme pattern of adversity, a very sort of homogeneous pattern of adversity. So
have many of them died?
in the institutions, it's hard to say.
No, but since they got to the UK?
Oh, right.
Given that they're probably a propensity to risky behaviour from what you've described?
Yeah, it's actually incredibly sad. We've just lost two last year for suicide, actually. That's been incredibly hard for the team, actually, as of course, as well as for the families. So I think overall we've had three deaths.
So what you've been doing is looking at the brains to see if there's some sort of pattern, anatomical pattern that you can pick up, and also to do with the size of the brain. What have you found?
Yeah, exactly. So if I could focus on 5 really important findings. And just before I describe these, this is only the first stage of the process. This is one part of the brain imaging data. So it doesn't rule out the possibility of other effects on other aspects of brain development. So we're focusing on brain structure, as you say, brain volumes and brain structure. We invited the young people to come in for brain imaging session, and we did a kind of a typical brain imaging protocol, standard protocol, state of the art. And what we found were 5 things. First of all, deprivation was associated with reduced brain volume and substantially reduced brain volumes.
And you could say that because you've got a control group of the same age group.
Yeah, of course we have a control group of UK adoptees who are adopted at the same time, but from the UK with no history of deprivation. So that's the first point. The second point, and this is even more important, that there was a dose relationship. So the more deprivation they had experienced, the smaller the total volumes for grey and white matter in the brain. So,
in other words, the longer they had in the orphanage.
Yeah, the longer they had in those orphanages, the more deprivation they experienced, the smaller the brains. And this was a very linear kind of effect. We could see losing a particular brain volume per extra month in the institution and draw a straight line through that is really striking. So that's the first 2 parts.
And was that linked to IQ?
This is the third part. So it's all well and good saying, yes, there's an impact of early deprivation on adult brain.
But it might mean nothing.
Yeah, it might mean nothing, because of course we know that brain volume in itself isn't a predictor of very much in the normal population. So, but what we found was, and this was the third really important thing, is we found that it did seem to be related to 2 things. Increased risk for ADHD, attention deficit hyperactivity disorder, which is a very, very common feature in our sample, and low IQ. So it had a functional significance, which was really, quite compelling. It kind of brought the story together of what we'd seen previously and the brain data. So those were the first 3 things.
Now, the brain is very adaptive. Did you find any adaptive response that helped them?
Yeah, so there was one area that we found in the brain. So as well as looking at the total brain volume, we looked at regional variations in different important parts of the brain that regulate different activities. So as you mentioned, the frontal lobes, for instance. So we found regional effects in the frontal lobes over and above the total brain reduction in volume. And very interestingly, we found an area in the temporal lobe, inferior, so the bottom part of the temporal lobe.
This is the area behind the ear, if you like, if you're thinking of it from the outside in.
Yeah, but at the bottom of that, so kind of under the bottom of the brain, it's an area called the fusiform, kind of extended into an area called the fusiform gyrus, which is very important in visual processing and particular has been linked to face processing, for instance. A very interesting area for us. And what we found was that was actually differentially spared. So once you've controlled for the total brain volume, we found that for some of the deprived children, they had a larger inferior temporal lobe than we would have expected from the total brain volume. And the crucial thing there was that was associated with less ADHD. So for some of the deprived children, they had a larger inferior temporal gyrus, and that seemed to be compensatory or protective or associated with resilience in some way in relation to ADHD.
And what was the final thing you noticed?
So the final thing is a negative finding. So there's been a lot of research in the past looking at brain structure and the limbic system. So this is the system that regulates emotion. And people have shown it very sensitive to stress, early stress, for instance, in animal models and in other models, human imaging studies. So we really predicted we'd see an effect on the limbic system, and so particularly one area called the amygdala, which listeners have probably heard of. It's the area that regulates emotion and processes negative emotions. And we found nothing. We found no effects at all in any of the limbic structures. So that was a big surprise, which really highlights the point we made at the start of the interview, that you can't necessarily generalize from this pattern of adversity that these children experience, this neglect, this extreme neglect, and this extreme deprivation, to other forms of adversity. We didn't show a classical effect of stress on the brain in this sense. To consider their deprivation as a stressor or associated with stress or even the word trauma might be a mistake. Privation, deprivation isn't a straightforward trauma or stress.
Now, regrettably, there are millions of deprived children in the world. There are plenty in the UK and plenty in Australia. Are there general comments you can make about not necessarily what happens, but about adaptation, about compensation, about plasticity that might inform a better approach to deprivation?
Yeah, I think it's very interesting that at the moment I'm chairing a commission on the whole issue of deinstitutionalization. It's a commission from the Lancet. We are just putting together the final document. People from around the world, experts in institutional care policy and so forth. And you're absolutely right. We estimate a minimum of 5 million children still living in institutions. So this very particular form of developmental deprivation. So it is a real issue still. The key thing is prevention, of course, to try as hard as we possibly can not to place children in those institutional settings, to find alternative family-based or family-type care for children. I mean, that's got to be the first priority, and that's certainly the recommendation that we're making. So as far as we can, place resources into trying to develop alternatives, so increasing foster care, increasing adoption across the world. And that's a real challenge, of course, because different cultures have different attitudes to aspects of the family. But that's got to be the main thing. If it's absolutely necessary, because, of course, for child protection purposes, sometimes children have to be taken from their families or sometimes their parents die. If it's absolutely essential, make it as short as possible.
So what does it say about therapeutic interventions? Because these children would have had therapeutic interventions. You implied that. We've got a new generation growing up having read Norman Doidge or heard him, and talk about the plasticity of the brain and believing it all. But there's obviously a limit to that.
Well, I think you've hit the nail on the head. I think what our data shows, and this is the most compelling part of our data, that despite this wonderful super enrichment that these children have experienced, there are limits to plasticity. There are limits to rehabilitation. I mean, if you think about it, they've had 25 years of very high quality intervention. They haven't always got the help from the state that they've needed. That is certainly true, and that's been an issue that we've explored a lot. But it's been an enormously a powerful intervention, and yet we still see these difficulties. And I think that's the sobering part of our story, that the concept of plasticity is clearly a vital concept in neuroscience, and it is a double-edged sword. Clearly, the initial exposures had an enormous effect on the brain during at least those early, potentially critical periods. And, the adoptive experience has had, I'm sure it's had an incredible effect on the young people. It's clearly been incredibly beneficial, but it hasn't completely erased either the brain signal or the consequences for the young people.
Hence your emphasis on prevention.
Yeah, absolutely. I think that's, as you said, they've tried all sorts of interventions. So, for instance, if we look at ADHD, as many of our children have had a diagnosis of ADHD, I think we found 35% of our children had a diagnosis or met the criteria for a diagnosis of ADHD as adults, those, exposed to extended deprivation. So, and they've tried the normal treatments for ADHD in terms of medication-based treatments, as you'd expect. And when I speak to my colleagues, my clinical colleagues, they say, who've worked with these young people, they say they can't see the difference in how they respond compared to other people with ADHD. So it's a similar clinical challenge at the level of the particular problem that they've got. But if we can remove the cause, clearly that's got to be the best way to go forward.
Thank you very much indeed, Edmund, for talking to us.
No problem.
Edmund Shanunga-Bark is Professor of Developmental Psychology, Psychiatry and Neuroscience at King's College London. And you're listening to RN's Health Report with me, Norman Swan. Recently, 3 papers in the prestigious New England Journal of Medicine marked what looks like a significant advance in the treatment of ovarian cancer. Ovarian cancer is often diagnosed late and the prognosis can be poor, and improvements for these women have been slow in coming. Hence the excitement in these trials of medications called PARP inhibitors. I use that as an excuse to catch up on some of the latest research into ovarian cancer with Professor David Botel, who's co-head of women's cancer programs at the Peter MacCallum Cancer Centre and principal investigator of the Australian Ovarian Cancer Study. And I also spoke to George Oyoung, who's a medical oncologist and a researcher in the program himself. Welcome to the Health Report to you both. George, let's go to the clinical side of things. How does ovarian cancer present?
Yeah, so the most common way ovarian cancer presents is actually with very non-specific symptoms. None of them
like
sort of
tummy upset, feeling bloated.
Those are the most common symptoms, sort of change in bowel habit, bloating and nausea. And these symptoms can often be attributable to other conditions. And I think if you took 100 women with these symptoms, only a very small proportion of them would actually have ovarian cancer.
And diagnosis is a problem, but let's just go to early detection, because a few years ago there was a lot of controversy because some commercial pathology labs were saying there's a blood test that would detect it early, which is the same test you use to monitor progress. But that's a myth, really.
Yeah, that's certainly a myth. I mean, there's been a whole body of work to try over the last 20 years to try to identify a method to detect ovarian cancer at an earlier stage. And unfortunately, we've not been able to identify a robust test that will be able to pick up ovarian cancer at an earlier stage, at which we can intervene and hopefully reduce the development of disease recurrence.
Let's say, for example, a woman presents to the GP and she's got these troubles, or these tummy troubles, they're out of the blue, slightly older woman, and there's maybe some ovarian cancer in the family. What's the test that the GP refers for?
There's no one test that will say this is ovarian cancer, and the definitive diagnosis typically comes from a surgical removal of whatever is detected. In those sorts of cases, patients often undergo some basic workup and then really need to be referred to a gynae-oncologist who's a specialist in the field, who has the ability to assess all of the findings together and come up with the most likely diagnosis, and then would typically proceed on to having surgery where the definitive diagnosis is being made.
David, just give me a sense of how challenging ovarian cancer is as a tumour compared to others.
I think it's challenging on a few fronts. One is that ovarian cancer is kind of a misleading term. It suggests a single disease, and it absolutely isn't. It's a series of different diseases that really share a location in the body. And it's taken us a while to realise that, but we now know that.
So what are the different diseases?
The most common type are high-grade serous ovarian cancers. They are associated with about 70 to 80% of new invasive ovarian cancer cases. Then there are a series of maybe 3 or 4 other less common types, so clear cell, low-grade serous, and so on. And they are all very different to each other, as different as breast and kidney cancer are to each other.
With different prognoses?
Yes, with different prognoses and different responses to treatment. Treatment for ovarian cancer is very much driven by the response profile of the high-grade serous cancers to platinum and taxanes.
2 categories of chemotherapy.
That's right. And the other types of ovarian cancer tend to be much less responsive to that standard therapy.
So they have worse outcomes?
They can do. In some cases, for example, for some low-grade and clear cell cancers, they can be diagnosed quite early and cured surgically. They don't necessarily have a poor outcome, but if they've spread extensively, then often there is not a very good response to treatment.
Now, I did an interview once, not so long ago, in British Columbia, where based on their assumption that in fact ovarian cancer wasn't ovarian cancer at all, but a cancer that starts in the fallopian tube. In other words, if you think of it as a baseball mitt catching the eggs as they leave the ovary, that's where the cancer started, and they had a program with it when women were being sterilised, they removed the fallopian tube, and in so doing they believed they were going to prevent a lot of ovarian cancer. How true is that the fallopian tube is actually where ovarian cancer starts?
I think that's Jessica McAlpine's study at BC Cancer Centre, and it's true that high-grade serous cancers, this common type, we think arises from cells that are in the fingertips, if you like, of the fallopian tube and then rapidly spread to the ovary.
Is there any evidence that early detection increases survival, or you just live longer knowing you've got the tumour?
In the studies that have been published to date, there's no evidence of a survival benefit in the screened population. So that's really the key thing with any early detection test, is not how many cancers you detect, not how early you detect them, but really whether you actually improve the survival of people who have been screened. Because as you say, you may just simply be detecting something earlier but not changing the outcome in the end.
Now, George, surgery is still the basis here, assuming it's operable, that from an expert gynae-oncologist is still the core treatment to start off with, where they remove as much as they can. And then you move on to chemotherapy. Now, there's been 3 papers in the New England Journal of Medicine recently, which is one of the reasons why I decided to do this interview, on things called PARP inhibitors in the serous form, the more common form of ovarian cancer. How promising were those findings in what's been a fairly depressing landscape?
So I think just to go back to your point about surgery, I think, yes, surgery is an important part of the management of ovarian cancer, but that's now a more considered decision. Historically, surgeons used to go in and heroically try and resect as much disease as possible, but the honest truth is that the determinant of outcome, as David pointed out before, is really how sensitive that tumour is to chemotherapy. There's this description of biology over brawn being the main determinant of outcome.
But you are affected by how much tumour is there, and the less tumour you've got, the more likely you are to get some effect from the chemo, or is that a myth too? It's called debulking.
Debulking is an important part, but the data would suggest that the benefit of debulking surgery really only exists if you're able to completely remove all of the cancer and have what they call optimal debulking. If a surgeon feels as though they're not able to achieve optimal debulking prior to the surgery, then doing suboptimal debulking is not thought to actually have a great deal of benefit in the long term.
Now, David, one of the problems with ovarian cancer is that people become resistant to chemotherapy quite quickly. What are you learning about resistance?
Yeah, I think in another conversation we had, you described it as the devilry of these cancers, and it's a good term. The evolution of drug resistance in cancer in general is really the elephant in the room in terms of getting long-term control and cures for cancer. It's a lot like antibiotic resistance in a way. Here, these are cancer cells which are part of us, in the same way evolving resistance to the treatment over time. We have an incomplete understanding of all the different ways that can occur. We know some of the most common ways at the moment. We're trying to document the different mechanisms of resistance and understand why some patients develop resistance relatively rapidly and others maybe never, because that might give us ideas about how we can prevent the development of resistance.
What have you found about that?
A couple of mechanisms to use as examples. Many people will be aware of BRCA1 and BRCA2 germline mutations.
These are the two so-called breast cancer genes, the BRCA1 mostly in Ashkenazi Jewish populations, which vastly increase the risk of both breast cancer and ovarian cancer.
That's right. So they're part of a little nanomachine, if you like, that's involved in DNA repair. And when they're defective, that increases the risk of developing cancer because with the inability to repair the DNA in a cell, it kind of corrupts the code and that leads to the development of a cancer. But it also means that the cancer is very susceptible to chemotherapy. That also means that there is a huge advantage to any cancer cell that can repair that inherited mistake, can correct the mutation in BRCA1 or BRCA2. And so surprisingly, what can occur are these reversion mutations where there's a mutation near the one that was present in the germline.
Which fixes up the problem.
Which fixes the problem, amazingly. Another mechanism is the activation of a little pump on the surface of the cell. This has been really led by Liz Christie in our lab that has demonstrated pumping the chemotherapy out of the cells.
So these new drugs, I mean, what are we looking at in terms of improved survival?
I think what's clear is for patients with germline BRCA mutations, the ones we mentioned before, patients have their chemotherapy as what was thought to be standard of care, and then following that to have these PARP inhibitors, oral tablets, as what they call maintenance therapy after the completion of their chemotherapy. And the data is very consistent for BRCA carriers that they have a much better outcome.
But didn't these trials show that they also worked in people who didn't have the BRCA mutation?
Yeah, so that's the really interesting aspect of these newer trials. They didn't restrict the patients to only those with BRCA mutations.
David, are you finding any medications that help with resistance?
It's challenging. The first step is to really try and understand the mechanisms and see whether that brings with it some opportunities for different therapy. In the case, for example, of the pump that I mentioned earlier, you can imagine two different approaches. One is to inhibit the pump, to stop it pumping chemotherapy out, or simply to choose a drug where the pump is unable to push it out of the cell. It's the latter approach that we've adopted at the moment in a clinical trial. One of the real challenges is we don't know in a particular patient whether they have 1, 5 or 50 different mechanisms of resistance in their cancer. If there's 50, it's going to be very difficult to reverse that.
David Botel, who's co-head of women's cancer programs at the Peter MacCallum Cancer Centre in Melbourne, and George O'Young, who's a medical oncologist and a researcher in ovarian cancer as well. You've been listening to The Health Report with me, Norman Swan. Look forward to your company next week.
You've been listening to an ABC podcast. Discover more great ABC podcasts, live radio and exclusives on the ABC Listen app.